Hey guys, welcome back to my channel. This is Omar the Great, and today we are going to talk about shock. What is this concept of shock? It's a very important concept in physiology and also in medicine, and there are so many emergencies of shock that actually tend to happen on our emergency wards and even other clinical and medical wards. And even obstetric wards actually. So, what is shock? Shock, this is a condition or a state of the body in which there is decreased blood supply to the tissues. And this decrease in blood supply usually results into damage to the tissues following hypoxia or a decrease in supply of nutrients. So to put it into perspective, shock is a condition where we have decreased blood supply, which brings about damage to the tissues, and as a result of hypoxia and decreased blood supply to the tissues. So what do we need to know about shock? In our discussion of shock, we need to know about one, we need to know the definition, which we have just defined. We need to know about the different types of shock. And then physiologically, we shall need to know about the different phases or the progression or stages. You can call them stages of shock. Okay, so as I've already defined, different types of shock, we basically have 4 types of shock, where one, we have what we call hypovolemic shock. 2, we have what we call cardiogenic shock. And then 3, we have what we call obstructive shock. And then the 4th one is what we call the distributive shock. So broadly, these are the 4 categories of shock, and this is how we classify shock. So we're going to look at each of them in detail. So let's start with hypovolemic shock. So if we just look at hypovolemic shock, let's start with hypovolemic shock. So as we look at each of these different types of shock, what do we need to know under each? You need to know, this is the approach we are going to use. Under each type of shock, be able to know what are the different types here. Be able to know the causes of each of those types of shock, and then the mechanism in which these bring about shock. Okay, these are the things that you need to know about them. How will they bring about this decreased perfusion or decreased blood supply to the tissues, and eventually tissue damage following hypoxia and decreased nutrient supply? So hypovolemic shock, just like from what you can hear, hypovolemic shock. So which means the problem here is actually volume. So there is a hypovolemia, okay? So hypovolemia, so or decrease in volume. So we have a failure of volume, or what we call a volume failure, okay? So there are different things that can bring about volume failure or hypovolemic shock. So under the causes, let's look at them. You could actually have an actual blood loss. So anything that can cause hemorrhage can bring about shock. So one, let's look at hemorrhage. Okay, hemorrhage. So which means anything that can cause you to bleed, can make you to progress, can make you to have shock. So things that can cause hemorrhage. If you had an accident, you engaged in a traumatic event and you had an accident, okay, and maybe you caused damage extensively to your lower limb and you're bleeding profusely, you can end into shock. So traumatic events can bring about shock. 2, there are patients who have bad or very terminal severe gastric ulcerations, or maybe any ulceration throughout the GIT, and they're experiencing bleeding, or maybe bleeding as a result following any tumors within or any other pathology within the GIT. You can have bleeding, so GIT losses, okay? You could have an upper GI loss or even lower GI losses, okay? You can also have, this is common in obstetrics, mothers who have ruptured ectopic pregnancies, these ones usually bleed extensively. Even those with ruptured uterus can actually bleed extensively, and you can progress into shock. Okay, so there are different things that can predispose you. You can list several of them. So two, there is also, you could actually lose actual plasma instead of losing blood as a whole or whole blood. You can actually lose plasma. So there are things that can cause plasma losses, and these can also predispose you to shock. What are some of these things that can bring about plasma losses? If you undergo extensive, you're really diureting, okay? So diarrhea, bad diarrhea can actually predispose you to extensive loss of fluid, and you can get into hypovolemic shock. Definitely, if you're vomiting excessively, okay, any pathology that can predispose you to vomit excessively, you see, like in different conditions, but also what's common in the obstetrics, you find, for example, there's a condition called hyperemesis during pregnant women, gravidurum, okay? So this can have excessive fluid loss, plasma losses. So generally, anything that can give you dehydration, okay, anything that makes you dehydrated or lose your plasma, and also can predispose you to hypovolemic shock. Also, we have the burns. So these ones all bring about extensive plasma loss. Physiologically, you can also talk about excessive sweating, which can actually also bring about plasma losses in any states or condition. So let's try and see, how does all these causes, how do they bring about the mechanism? How will they progress or bring about shock? So under normal circumstances, if this is our blood, I mean, let me just use this to illustrate. Okay. So you find you are bleeding. Okay. So you're losing a lot of blood. So you're bleeding, you're losing blood, or maybe you're having any plasma losses that are bringing about decrease. So what do? You're getting a decrease in your plasma or decrease in your blood volume. So if you look at this diagram here, you're having a decrease, what happens here? You're going to have a decrease in your blood volume, okay? So with a decrease in your blood volume, what does it cause? It is going to, as you decrease your blood volume, definitely your mean systemic filling pressure will also decrease. And when your mean systemic filling pressure decreases, you're going to have a decrease in your venous return. So you get a decrease in the venous return. When we get a decrease in the venous return, what happens? Remember the Frank-Starling law or mechanism, okay? Definitely this will bring about a decrease in your cardiac output. But what happens? Which means the amount of blood that is returning to the heart decreases. So your end diastolic volume is also actually going to do what? It's going to decrease. And when your end diastolic volume, which is the volume of blood within the heart at the end of diastole, that volume is going to decrease. When your end diastolic volume decreases, what happens? The amount of blood you can eject out in a bit also decreases, which is called the stroke volume. Your stroke volume also decreases. And when you come to this expression, when your stroke volume decreases, what happens? Your cardiac output actually also goes low. When your cardiac output has decreased, when you come to this formula, when your cardiac output has decreased, your mean arterial pressure also decreases, which is the perfusion pressure, which is the key pressure will lead to when I'm talking about shock. So the decreased perfusion pressure will predispose you to, this is decreased, meaning that decreased blood supply, then you have increased hypoxia and decreased supply of nutrients. And definitely you get into a state of shock and start presenting different symptoms of shock. Okay, so this is the picture. So for example, someone starts having very cold extremities, okay, so you get some of those symptoms come into play. So this is how actually that is how hypovolemic shock brings about, how volume failure brings about hypovolemic shock. Yeah, so the second one, let's look at the second type of shock, which is cardiogenic shock. So the second one we're going to look at is cardiogenic shock. 2 is cardiogenic shock. So in cardiogenic shock, what is the problem? Cardiogenic, which means cardio is the heart, is coming from the heart. So which means the problem is actually within the heart, okay? So this is, the heart usually does the pumping action. So the pump is failing. So that's what we also tend to call the pump failure, okay? Just to help you remember the mechanism. So in mechanism, you remember a mechanism bring about the failure, the bring about the shock. The mechanism here, the problem is the volume, and then this side is the pump, okay? So in cardiogenic shock, what's happening? So the problem in the heart, there are different things that can make you have cardiogenic shock. This is the best approach I can give you. So we have, the heart is comprised of, it has the myocardium, okay? It has the myocardium, okay? It has valves, okay? And also has the what? The conductive system. The conductive system. So functionally, for me, this is functionally, this gives me a picture, which means any problem in the myocardium can actually predispose you to failing of the heart. If the valves are failing, the heart will also fail. And also if the conduction system is failing, which is initiates the electrical activity in the heart, which means you will not have the contractility or contraction activities of the heart. Definitely the pump will also fail. So let's look at some causes. So when you look at under the myocardium, okay, the myocardium. So causes under myocardium, you can actually look at one. You could look at the myocardium can undergo inflammation. So myocarditis, okay. Different things can cause myocarditis, okay. Infectious processes like the Coxsackie virus, okay. This one can bring about myocarditis. You can also have various causes of a cardiomyopathy, okay. Let's call it cardiomyopathy, okay. So another cause you can have cardiomyopathy, okay. And these ones you could have the different types. You could have what you call, there is what you call a restrictive cardiomyopathy, okay. So restrictive cardiomyopathy, this means that the heart is stiff, okay. In this case, the heart is stiff. So anything that's causing the heart not be able to expand, to fill with enough blood, and also not be able to, to contract. So the heart is stiff, okay. The myocardial walls of the heart are stiff. This is what we call a hypertrophic cardiomyopathy, okay. So hypertrophic cardiomyopathy usually happens in chronic states when you have a prolonged chronic fluid overload, okay, chronic volume of fluid or chronic overload. Let's just call it chronic overload, okay. So when you have chronic overload, what happens? The heart adapts. So the heart becomes wide, okay. So the heart broadens and the chambers also broaden. So let me briefly tell you about this. So if you look at restrictive cardiomyopathy, so if the heart is not able to, to distend or to expand or to relax, able to fill with enough blood, what is going to happen? Which means it cannot, no matter how good the venous return is, it cannot fill enough at diastole. So you get a decrease in the end diastolic volume. Then you get a decrease in the stroke volume. When stroke volume decreases, cardiac output decreases. And when cardiac output has decreased, mean arterial pressure also does what? Also decreases. If you're having a problem, if the problem is the heart cannot, it is stiff and cannot pump enough blood, it cannot eject a good volume of blood. Stroke volume definitely decreases. When stroke volume decreases, cardiac output decreases, and then mean arterial pressure will also decrease. In hypertrophic chronic overload, you find the heart is distended, okay? So the heart is filling with a lot of blood, especially the ventricles, for example, they're filling with a lot of blood, but they cannot contract ably with enough force to eject the blood. So they have good volume that at the end of diastole, but they cannot eject a good stroke volume. Definitely the stroke volume that they're ejecting is decreased. So decrease in stroke volume will give you a decrease in the cardiac output and decrease in your mean arterial pressure. So we also have another type of cardiomyopathy, which is called a toxic cardiomyopathy. And this one usually results from different poisoning, from maybe lead, different metals, cobalt, okay, and also excessive alcohol consumption can also predispose you to this failure of the heart. So the mechanisms are quite related. There are also other pathologies within the heart that can also predispose you, that can affect the myocardium, for example. We also have what you call, if you heard of Chagas disease, okay, where you have these different microorganisms, the trypanosomes, okay. These trypanosomes have a preference to damage the myocardium, and so damaging the myocardium definitely is going to affect the ability and the contractility of the heart, okay, the contraction ability of the heart. But also we have Lyme's disease, okay, Lyme disease. So this Lyme disease usually is as a result of usual pathology originating from these tick-borne spirochetes, okay. So these tick-borne spirochetes can actually damage the myocardium, and for them they have a preference to the conductive system of the heart. So when they can actually tend to cause sort of heart blocks, okay. So they have a preference to damaging the conductive system of the heart. So they can actually cause heart blocks. So when you cause a heart block, what is going to happen to your heart rate? Is going to decrease. So you're blocking the electric activity that is supposed to cause contractility in the heart. You get the point? So that's what is happening. So decrease in the electric activity in the heart is going to bring about decrease in the heart rate, and decreased heart rate directly will decrease the cardiac output, and decreased cardiac output will decrease the mean arterial pressure. So this is how this brings about. So the other thing maybe we haven't looked at are the valves. So these valves, okay, there are two things. These valves can either be, they can fail to open, okay, or they are sustainable, they are constantly closed, or they are narrowed or closed. So they can be in a state of what we call stenosis. So there are two conditions. We can have valvular stenosis, and also we can have valvular regurgitation. Okay. So regurgitation, this is when the valves are incompetent, okay. So if these are the valves, if this is our vessel, so the valves are not closing ably, closing. So definitely when the ventricles, if this is, you see we have valves here, for example, these are the pulmonary valves. So as the ventricles eject blood, under normal circumstances they open and then they close to prevent a backflow of blood. But what happens if pathological states, you find you're ejecting blood, so blood is ejected, but because they cannot close very well, you find there is blood that actually regurgitates and comes back. So what is going to happen? You're ejecting volume of blood, okay? You're ejecting stroke volume up, but you've ejected this volume up and then some volume comes back. Definitely the total amount of volume ejected is going to what? To decrease. If you're going to calculate, if you're going to estimate the volume of blood ejected in each beat of the ventricle, you're going to realize that the stroke volume is actually going to be low. When you have a low stroke volume, cardiac output decreases and mean arterial pressure also does what? Decreases. So even for stenosis, so if this valve is completely closed, meaning that you're not ejecting blood, definitely the stroke volume is going to decrease, cardiac output will decrease, and mean arterial pressure will also do what? Will also decrease. So this is about the cardiogenic shock. So the problem is the heart, the pump, and this is affecting the contractility, either affecting the stroke volume or the heart rate of the heart, and definitely decreases the cardiac output, and even the mean arterial pressure also decreases. Yeah, so we are done with hypovolemic shock. We're done hypovolemic shock, cardiogenic shock. So let's look at obstructive shock. So in obstructive shock, what are the different causes of obstructive shock, and also by what mechanism will they bring about shock? So in obstructive shock, so there are different causes. One, you can have a massive pulmonary embolism. Okay. So what happens when you have a massive pulmonary embolism? Look here. If I have a big embolism that are dislodged, okay, and comes and maybe blocks here, okay, so what is going to happen? I come and block my venous return. I block here, okay. So the blood returning to the heart is actually we have a blockage in this return of blood to the heart. So what's going to happen to the end diastolic volume is actually going to decrease, okay. the volume of blood that the heart is able to receive at the end of diastole decreases because we're having a blockage, okay? And so decrease in end diastolic volume, even the stroke volume will actually do what? Decrease. Decrease in the stroke volume will decrease the cardiac output, and that will decrease the mean arterial what? Pressure. Now, another cause is what we call, you could have what we call a tension pneumothorax. You could have a tension pneumothorax, okay? So let me illustrate this. You have a tension pneumothorax. If these are your lungs, so under normal circumstances, you find in the chest cavity, we have the lungs like this with our heart, okay? It's in the middle there, and then we have our thoracic cavity here, okay? So what happens during when you get a tension pneumothorax, it is pneumothorax, which means pneumo is air. Air is entering into the thorax. So you get, maybe usually follows a traumatic event, or you have an accident and you get a prick, okay, or puncture of your thoracic cavity. So what's going to happen? You're going to start having air that is rushing into the cavity. And what is funny, so as you keep breathing in and out, this, when you actually, as you're breathing in and out, this air does not actually seep out. It forms sort of a valve, okay? So it's like something like this. So air is moving in. As you're trying to increase the chest cavity, instead of this air moving out, you find this air is actually, this causes a closure of the valve and air is trapped inside, okay? And then when the chest volume decreases, then the air also comes in. So eventually you're going to have increased accumulation of more and more air within the chest cavity. Now this air, what does it do? It's going to start compressing onto the lungs. As the lungs are being compressed, they're going to be pushed to one side, okay? So as the lungs are being compressed, you're going to see they're being pushed. You find now the lung starts collapsing because of the air that is pushed, and it's going to start compressing the heart and also pushing. You're going to have the mediastinal shift from this side to the other side, okay? So definitely you're going to have compression of the what? Of the heart. So if the heart is under a lot of restrictive forces, okay, what is going to happen? It cannot ably fill. Remember, it cannot now fully expand or relax to fill with a good volume. And so it is going to, we're going to have problems with filling the heart. So when you have problems with filling the heart, which means the amount of volume that can be filled in the heart at the end of diastole is actually less. Decreased end diastolic volume, not so? After at the end, when end diastolic volume decreases, the amount you can eject out also decreases, which is the stroke volume. When stroke volume decreases, cardiac output goes low, your mean arterial pressure also decreases. So that is it. Another thing is actually what we call a cardiac tamponade. Cardiac tamponade. Okay. So in cardiac tamponade, this is what happens. You find you have, remember anatomically the heart has a pericardium around it. And this pericardium is actually filled with usually some fluid, some mils of fluid, okay? Pathologically, sometimes this pericardial cavity is actually gets contaminated, or can be, instead of having normal fluid, you find you could have actually pus, okay? You could also have blood or hemorrhage, okay? So you could have blood accumulating here, okay? And as blood keeps accumulating, what is going to happen? This blood or pus or whatever is accumulating here starts causing compression to the what? To the heart, okay? So we are restricting the ability of the heart to expand or to fill and to perform its pumping activity. So the heart starts becoming ineffective. So you have an ineffective heart, which means it cannot fill adequately. The end diastolic volume will decrease, the stroke volume will decrease, and your cardiac output will decrease, and your mean arterial pressure will also decrease. The other type of shock is actually what we call this one here. Is what we call the distributive shock. Distributive shock. Distributive shock. Okay. So in distributive shock, there are actually different types. We have about 3 types. So this, I usually remember it like, we know this, the heart has the pacemaker, which is the sun, which is the SA node. So this is how I easily remember them, and this can help you, okay, for you to remember. Yeah, so we have, so S stands for septic shock. A stands for anaphylactic shock, and then N stands for neurogenic neurogenic shock. So let's look at the different types of, or let's look at each of them in detail. So when you look at septic shock, usually this one is common even on the medical wards, okay? So most of these, usually it's about maybe infectious process, or in cases of like TB, okay, you have maybe HIV, or even maybe like malaria, okay? So no matter the cause, okay, you can have an endless list. Usually the problem, maybe for example, it's like in TB, a bacteremia. The problem usually is these microorganisms, they tend to produce endotoxins, okay? Endotoxins. So these endotoxins, when they are produced, what do they usually do? These endotoxins, they tend to bring about vasodilatation. They bring about massive vasodilatation. Okay, so if I'm to remind you, and what vasodilatation does, it actually decreases the total peripheral resistance. If I'm to remind you briefly about our hemodynamics, okay, so you find we said resistance is directly proportional to the viscosity and the length of the vessel, and then inversely proportional to the radius, okay, to the radius of the power 4 and also the pressure gradient. Okay, so what does this mean? If I increase the radius, okay, which means my resistance will go low, because resistance is inversely proportional to the radius. You get the point? So if I increase the radius of this vessel, okay, by maybe 4 times, or if I increase the radius, definitely my resistance, the resistance in this vessel, the resistance will actually now decrease, and that's what the principle these are employing. So this endotoxin cause massive vasodilatation. They increase the radius. When you increase the radius, resistance goes low. So when so definitely your total peripheral resistance decreases. When your total peripheral resistance decreases, what happens to your mean arterial pressure? Your mean arterial pressure will also do what? Will also decrease. All right. So then, when we look at anaphylactic shock, what happens in anaphylactic shock? This one usually follows usually as a result of different allergic reactions, okay, or IgE mediated reactions. So you can have allergic reactions more commonly, okay, and in practice I've actually met a man who has been stung by bees, okay, and got into anaphylactic shock. So these bees stinging you can actually predispose you to anaphylactic shock, and also exposure to any other molecules that brings about a IgE mediated response in your body. So what happens? These antibodies here, which is this IgE, usually binds onto its receptors that are found on the mast cell. Okay, so when they bind onto these receptors that are found on the mast cell, what do they induce? They're going to induce degranulation of these mast cells. So these mast cells now start to release their contents, okay. So and some of these granules that are released into circulation, these granules actually contain some substances, for example histamines, okay. So these histamines, these are typically vasodilator substances, okay. So histamines that are released will bring about massive vasodilatation, and when you have massive vasodilatation, definitely your total peripheral resistance will also decrease. And as we already said, when your total peripheral resistance decreases, you're going to get a decrease in your mean arterial pressure. Okay, so let's look at the last one, which is the neurogenic shock. So let me put it here. Neurogenic shock. So this one, usually there are different things that bring about this. You could have a patient actually undergoing any surgery or what, and they're subjected to general anesthesia, okay, they are at a risk. Then you could have actually some, especially maybe those undergoing cesarean sections and they are subjected to spinal anesthesia, they are also at a risk. You could also have those that are under drugs, okay, different drugs that will block the sympathetic nervous system. This can also predispose you to getting to neurogenic shock, okay. But also you get traumatic events, okay, traumatic events. which traumatic events may involve damage to the sympathetic trunk. Okay, maybe you have a spinal cord or vertebral damage. You get a damage to your sympathetic trunk. Okay, this can also predispose you to having this kind of shock. But also there are patients who get actual cerebral damage. Okay, or damage, or let's just call it brain damage. Okay, so they also have who get brain damage. Okay, maybe brain damage, or maybe they've had a concussion. Okay, or even maybe a contusion. So all these will actually tend to predispose you to neurogenic shock. They are different. These are some of the causes that can bring about neurogenic shock. But how do they bring about? What's the mechanism? Okay, so the mechanism is very simple. You know, the biggest issue here, if you're seeing anesthesia and all these sympathetic, so we are damaging the sympathetic input, okay, to these vessels, for example, okay, to the vessels and even to the heart. Okay, so when you have a damage, you know, you're damaging the nervous input, okay, the sympathetic nervous input into these vessels. So you're going to have what you call when you have damage, you're going to get remember, vessels are usually under a vasomotor tone, which is usually brought about as a result of the activity of the sympathetic nervous system. So when you lose this input of the sympathetic nervous system, then you're going to get a vasomotor failure, okay, vasomotor tone failure. So you get this loss of vasomotor tone, okay. So when you lose this vasomotor tone, what is going to happen? The vessels are going to dilate, okay. So you're going to get massive vasodilatation, and when you get this massive vasodilatation, what is going to happen? Like we've seen your total peripheral resistance is also going to decrease. And when total peripheral resistance decreases, what is going to happen? Your mean arterial pressure also decreases. Okay, yeah. So this is how the different types of shock can be discussed in a simpler way, and also there are different causes and their mechanisms. Okay, so please, you can review this at any time. If you've not understood something, pause, rewind, okay, take back, and even forward, and enjoy this video. All right, so keep tuned in for part 2 of this video, where we're going to talk about the different phases and progression of shock. Thank you.